First of all, I'd like to thank you for the kind invitation. It's an honor to present on this such important occasion. I hope that you're able to see my screen. So today I wanted to present and to talk about the liver involvement in cancer patients, and especially in patients with unresectable hepatocellular carcinoma. As we know, up to 90% of hepatocellular carcinoma cases arise in the setting of underlying liver diseases. And as has been showed in a recent paper published on hepatology in 2025, liver decompensation occurring during systemic treatment represent a major determinant of mortality in patients with HCC. And we know, but it's not sure percentage, but if we look at real world data, we can say that approximately 20-25% of patients with present with unresectable hepatocellular carcinoma have a liver function classified as Child-Pugh-B. And the treatment landscape for HCC has recently evolved. And in Europe, we have two new combinations for first-line treatment, the combination of atezolizumab plus bevacizumab and the combination of durvalumab and tremelimumab. And we can use a lot of TI as second line, as well as the anti-VEGF ramucirumab. But the problem is that all these clinical trials have included patients with a liver function classified as Child-Pugh-A. But in real-world practice, we know and we have seen that we have to face with 20-25% of patients that have Child-Pugh-B patients. And so should patients with mildly decompensated cirrhosis be offered systemic therapy? And it's a controversial question. And according to the EASL guideline, patients with decompensated cirrhosis should not be routinely treated with systemic therapy outside a prospective clinical trial, but however, therapy may be considered in carefully selected patients. And so how are these patients? Several efforts have been done in the past. If we look at the GIDEON studies that included patients treated with sorafenib, they show that for sure the overall survival of patients with Child-Pugh-B liver function is worse than patients with Child-Pugh-A function, but there's a difference if we consider the different points of Child-Pugh-B with overall survival that is longer in patients with Child-Pugh-B7 function, liver function, compared to the patient with Child-Pugh-B9. And what it's interesting that it's not shown here, but the Kaplan-Meier of time to progression are the same, meaning probably that liver function is a major, plays a major role in determining overall survival. And regarding immunotherapy, patients with Child-Pugh-B liver function have been involved in the cohort 5 of nivolumab, and the Kudo and its group observed that there's a median overall survival for patients with Child-Pugh-B cirrhosis that are treated with nivolumab of 7.6 months. And so there's a good survival. And if we look at the adverse events are not higher compared to patients with Child-Pugh-A. So we know that patients can have a good overall survival, patients with Child-Pugh-B liver function, and the adverse events are not higher compared to Child-Pugh-A. And this is have been demonstrated also in a recent meta-analysis. If we looked for sure, we know that the overall survival and progression-free survival is worse for patients with Child-Pugh-B, because if you look at the first forest plot, we can observe that patients with Child-Pugh-B have a higher risk of 2.72 compared to die compared to patients with Child-Pugh-A liver function. And this is true and remains stable even when we perform an adjusted analysis. And if we look at the progression-free survival, we can say that patients with Child-Pugh liver function have a 70% higher risk of progressing compared to Child-Pugh-A. And this is true Also for patients treated with immune checkpoint inhibitors with a median overall survival that is described across the studies of 6 months and a progression survival of 2.68 months, even if we have to remind that these studies are very heterogeneous, as shown in the forest plot, like with an heterogeneity of 80% for the overall survival and 86% for the progression-free survival. But so we know that Child-Pugh-B can be treated, no more adverse events, even if the median overall survival and progression-free survival are shorter than patients with Child-Pugh-A. But so the question that we have to ask ourselves is, it works to treat patients with B liver function, and this is another studies that have been published in JAMA Oncology, where the authors showed that taking patients with Child-Pugh-B liver function that are treated with immune checkpoint inhibitors or best supportive care, the median overall survival of patients that are treated is 7 months compared to patients that are in best supportive care, that it's 4 months. So the answer is yes, it works to treat patients with Child-Pugh-B liver function, and as the active treatment maintain also significant association with overall survival, also the multivariable analysis. But so are all Child-Pugh-B patients the same? Can we treat all Child-Pugh-B patients? Here are some examples. So 3 different patients that obtain the same Child-Pugh score of B7, but very different phenotype. And so the concept is that we can treat Child-Pugh-B patients, but not all the patients are the same. And so we have to develop some tools to be able to identify patients with Child-Pugh-B liver function that could benefit from systemic treatment. And for this reason, we performed a multicentric retrospective studies in 12 centers. Most of them were in France, but we included also 1 center from Italy, UK, and South Korea. And we screened 1,691 patients with primary liver cancer treated by atezolizumab between 2020 and 2024. The inclusion criteria were to be diagnosed with an unresectable hepatocellular carcinoma, BCLC-B or BCLC stage, and treated by a first-line atezolizumab with a viable clinical data. So at the end, we included 1,499 patients with AIDS. And as you can see, 246 patients were treated with Child-Pugh-B liver function. And what we have observed, for sure, it's the same that other studies have demonstrated for other drugs and other treatments, so that the overall survival for patients with Child-Pugh-B liver function is significantly shorter compared to patients with Child-Pugh-A liver function or patients without cirrhosis, and with a median overall survival of 8 months versus 17 months. And the same results the results are the same regarding the progression-free survival, with a progression-free survival of 5 months for Child-Pugh-B patients and 8 months for Child-Pugh-A patients. And after that, we wondered, okay, but to answer the question if the patients with Child-Pugh-B liver function are all the same, we stratified for not for Child-Pugh class, but for Child-Pugh score. And as you can see in the forest plot, the risk and the hazard ratio increase for Child-Pugh-B9 patients with hazard ratio that are up to 3.4 for the overall survival. And the same results is shown in the Kaplan-Meier on the right, where you can see the purple line that represents Child-Pugh-B9 patients. The overall survival is extremely shorter. So what can help us to identify? So we know that Child-Pugh-B patients, B9 patients, go worse compared to child B7 patient, but there's any other tool that we can use to stratify these patients. And so we classified patients with child B cirrhosis according to the ALBI grade, that, as you know, is a continuous score composed from albumin value and bilirubin value. And as you can see, the dynamic of the hazard ratio is extremely different from ALBI grade 1 to ALBI grade 3. And if we look at the overall survival of patients with ALB1 or ALB2 liver function is significantly longer compared to ALB3 patients. And for this reason, we try to create a new score, a simple prognostic score for patients with CHIKV-B treated by atezolizumab, the ALBEX score, that is composed from ALBI grade and extrahepatic metastasis. That was another independent factor associated with overall survival in our cohort. And so we classified CHIKV-B patients in 3 different groups: patients with a good prognosis, that were patients with grade 1 or 2 and no extrahepatic metastasis; patients with intermediate prognosis, that were patients with extrahepatic metastasis; and patients with poor prognosis, that were patients with ALBI grade and extrahepatic metastasis. And as you can see, patients belonging to the group of CHIKV-B poor prognosis had a significantly lower overall survival and progression-free survival. We are not for sure the first to do that, and in a recent published GATT, another group tried to define a decision algorithm to treat patients with CHIKV-B liver function with systemic treatment, suggesting when to treat and not to treat patients, but and they identify for sure the iron burden and macrovascular invasion, but no definition of a subdefinition of liver function like the ALBI have been proposed. And so what we can say is that advanced HCC develops on most of the time on chronic liver disease, making liver function a central determinant of prognosis and treatment feasibility, and that CHIKV-B patients are not all the same. Survival is driven by the interplay between tumor burden and hepatic reserve, and so we have to develop some tools that could help the clinician to identify patients that could benefit from systemic treatment. And in patients with the atezolizumab, ALBI grade and hepatic disease allow a more refined and clinical meaningful risk stratification beyond the CHIKV classification, but for sure we need prospective trials to define tailored treatment strategies for these underrepresented population. And thank you for the attention.